Welcome everyone to the Zoom meeting. Today we will have different topics. So what we're gonna do, we're gonna start with topic number 2, Dr. Amr, and then we will follow that with the other topics, including pressure ulcers, research consent, medical AI. So Dr. Amr, when you are ready, you can start about the topic, sir.
Okay, just 1 minute because I want to make sure my voice is clear. I have to fix the connection issues. Just 1 minute.
Yes, please go ahead.
Is my voice clear?
Yes.
Okay, that's great. So hello everyone. Thank you so much for joining. My name is Dr. Amr Elmuiad. I'm really excited to be back speaking with you all again. I also hope everyone's enjoying the World Cup matches if you follow sports. If you're like me, you're probably having difficulty sleeping and fixing your sleep schedule because of the time zone differences and all of that. I'd like to thank Dr. Nadir again for this amazing opportunity at the TGRF at the Combined Research Foundation. Also, I'd like to thank the host. Uh, so this is actually the third part, you can kind of say, of this series. So 2 weeks ago, I started by presenting how to write a systematic review from scratch, like a sort of beginner's tutorial. And then last week, I presented on illicit AI, which was basically about how machine learning and AI can speed up our initial data extraction and scoping. But today, we're going to kind of bridge those two topics by focusing on the actual search. Uh, so while illicit AI is fantastic and great for extracting data from the papers, you actually need the right papers in your pipeline, and that requires a good research string, which basically means a good way to actually do the search. So today we're going to focus on the actual search strategy. If you've ever built a comprehensive database search, you know how it can be a bit tedious and annoying. Maybe a single comma apostrophe bracket can ruin your entire search and you won't even get the correct error code. So it can be a problem. So today I'm going to present on Search Refiner. It's an open source validation tool engineered by the wonderful, amazing team at Bond University. So let's kind of start in and see how it can save us a lot of time and effort. So there's this thing called the search bottleneck. So when doing a systematic review, usually the literature search is the most time consuming stage because the goal isn't to find a few relevant papers. It's to find every single relevant paper out there to your specific question, which sounds in theory reasonable and like you should expect to find every single paper. But it's actually very difficult because you're searching through massive databases like PubMed, Embase, which have millions and millions of publications. So it's actually kind of tricky in practice. So even after building what seems like a good search strategy, your research group or team might have to filter through thousands, tens of thousands of papers, and the majority of them are irrelevant, but you still have to make sure you screen them manually because you can't afford to miss out even one relevant study. So this is what I mean when I say the search bottleneck. So the search itself, you can just search and type away. That takes a few moments. But the screening and making sure you select the correct papers and filter out the relevant ones, that can take days to weeks, depending on how many people are doing it and how efficient and experienced they are. So that's why researchers spend so much time refining their search strategies before the screening process even begins, because you want to kind of be efficient, but at the same time not compromising any, uh, let's say, totality in the papers that you want. So, for example, imagine you're doing a systematic review on the treatment for hypertension, and you type your search and you get, for example, 20,000 papers. But your question might only require maybe only 200 out of the 20,000 questions, papers are relevant. So, like, there's a lot of junk kind of need to filter out. So the question is, how do we build a search, an ideal search, a perfect search that is comprehensive enough to get all the studies we want, but at the same time, it's not having all the studies that we don't want at the same time. So I called it the quest for perfect queries, right? You want to find the perfect sort of entry so you can get only the studies that are relevant without missing them out. So the thing with systematic reviews is that they rely on something called recall. And it's basically the ability to identify all relevant studies, all the relevant ones. And you also have to make sure that it's precise at the same time. Like I said, you can't have, you can, you could, for example, just search the word hypertension and probably get everything on that. But there's a lot of junk also. So you want to be precise at the same time. And you want to make sure that the Boolean logic that you're using, so the and, the or, and the not, you have to be kind of precise with those also, because if you don't, you risk your entire search strategy. So what is Search Refiner? It's open source, web-based. It's a free platform that helps researchers construct, visualize, and improve Boolean search queries. So instead of working only with long lines of text, the software provides like a visual sort of representation that makes the logic much easier to understand. It's also intended for junior researchers like myself, or maybe clinicians that have a lot of experience but don't have that research experience on their hands. So because it's web based, also you can have teams across the world working and makes collaboration much easier. So that's great. So let's visualize inquiry trees. So this is probably the most like unique or distinctive feature of Search Refiner. So normally, Boolean searches become increasingly difficult to read, right? Because you have this long change of and, or, nots, and nots. A systematic review might contain dozens of search terms, like including the mesh terms, the abbreviations, etc. Like at a certain point, it becomes hard to look at and hard to understand. So a nice thing about Search Refinery is that it makes it into this visual tree. This was supposed to be the image. It's not. It didn't download well on my computer. But the idea is that instead of looking at a long string of text in the search query of a bunch of mesh terms and, or, and not, the Search Refiner software gives you a nice visual way to look at it all and makes it easy to interpret and also quicker to interpret. So these are the core pillars, you could say, of the tool. So the first is the editor. So instead of, like I said, manually typing all the stuff down, you get to see it. You get to basically you get to add the terms by graphically adding them to the tree, and that kind of goes in hand with the visualization. So it's easy to visualize everything you search instead of having it in a long string of text. And finally, here's the validation core, which is important because it helps ensure that important reference papers, which are known as seed papers, I'll move on to that later, make sure that important reference papers remain included even after modifications to the search strategy. So for example, let's say you did a search strategy and you identified a paper that matches the research question perfectly. Now, let's say you're modifying your search because you're trying to filter out some bad papers. Since you identified that previous like I said, seed paper as important. No matter what you change to the search, it will still remain there because you yourself manually said this paper, no matter what my search, I want it to be there. So it's a kind of a human way of making sure everything's going smoothly. Uh, so like I said, it simplifies the workflow. Traditionally, refining a search strategy involves a lot of trial and error, and you have to make a mistake and you have to learn from the mistake. Researchers make one small change, rerun the search, record the number and compare the previous versions, and then repeat the process over and over. So it can be kind of boring and annoying. So Search Refiner helps to automate much of the process. So like instead of manually testing every single variation, the software, the computer, the Search Refiner software itself evaluates the query changes in the background, provides feedback to you. So that allows the researchers to focus more on improving the search strategy rather than all the tedious details in the background. And overall, this makes the refinement process much less dependent on guesswork. So just to put in, so everything I said is kind of clear, I'll give a brief example. So like, for example, imagine adjusting the filters on like a online shopping website. And as soon as you change the filter, the number of matching products updates automatically in a way. So like you get to see instantly what your change does instead of having to run the search again and again and again and wasting all that time. So that's a nice thing also. So here's like a 1, 2, 3, 4 step way you would do your search strategy. So the first step is to draft your strategy using to draft your questions or using the Pico format. And then after that, you want to visualize it. And that's the key thing about Search Refiner. You get to visualize your whole search strategy using a sort of tree diagram, if you can imagine that. After that, you get to validate it and compare it with your seed papers, which are the papers that you deemed relevant to your paper, regardless of what you searched. You deemed them relevant because you manually reviewed them. And after all of that, the query can still be refined if you want to trim out some poor studies. That also entails a bit of manual, you can say, screening. But most of the time here is consumed in step two. So even if you do end up wasting a bit of time in step threes and four, step two is the one that takes the most time. So if you save your time here, you end up saving a lot of time. So this is the problem with the search that I said in the beginning. So as you can see here, only around 1% of studies that you search end up being in the systematic review, and only 4% are potentially relevant. So 95% of studies are completely irrelevant to your search, but you still have to do them before Search Refiner because you couldn't afford missing even a single paper, right? So this is very, very time consuming to do manually because at the end of the day, you're only going to use around 1% of the papers that you find in your study, and only 4%, and another 4% are relevant. The rest are just junk. So that's pretty crazy if you think about it. So this slide kind of demonstrates the main findings. So the developers of the software, they did this benchmark testing thing where they found that up to 75% of papers could be trimmed out, but while retaining 100% of the relevant papers. I think it's on the next slide here also. Yeah. So you can trim out 75% of this while still retaining all of this important 1 plus 4, which is 5% here. So this is kind of what made Search Refinery very, very famous in a way, because you can cut out 75%. That can save you a lot of time without, because the thing with AI and computer machine learning is people always have this feeling that they're compromising integrity or they're missing out on a few studies. But the developers proved that you can keep all the studies that are relevant while cutting out the irrelevant studies. So it's kind of completely foolproof in a way. Uh, this is just a syntax comparison between Search Refiner, PubMed, and on and the Ovid Medline. So Search Refinery is very beginner friendly. You can write the terms in your own English language, and you don't need to be an expert in all these syntax, and you don't have to be an experienced researcher in a way. You can just kind of have novice experience like myself, and you can go a long way in searching for papers without being an expert. Like I said here, you can basically get 100%, they claim, of all the relevant studies without compromising anything. So some benefits for beginners I listed here. So you save a lot of time, and it's very easy to use. It's intuitive, and it doesn't take an expert. Also, their papers are reproducible, so it's not like and they also align with the Prisma standards, so your paper can be published, and there's nothing wrong with it in a way. So that's all. That's just a brief introduction in Search Refiner and how it can help us save time while extracting data and conducting our systematic review. So thank you everyone for listening. And if you have any comments or anything you'd like to mention, that would be appreciated.
Thank you so much, Dr. Amr. Any questions, please
Thank you.
go ahead. I have one request. Do you mind if you show us like a brief demo?
Yeah, sure. Just
Okay,
one
thank you.
minute. Just a second. Uh, because I had the link somewhere on Search Refinery. It is free, but they do have this sort of how do I say, like a pro version. So let me just log in here with my password. Uh, just 1 second because I want to log in. Um,
That's fine. Thank you.
yeah, okay.
Hello everyone.
Hello, Dr. Abdullah. How are you?
I'm doing fine. Thank you so much. I'm actually late because I thought that the meeting had started 2 p.m. Sorry about
That's
that.
fine.
Okay, thank you so
So,
much.
Dr. Amr will do a demonstration, and then after that, if you are ready, you
Okay.
can start after him. And then Dr. Alaa, I think she is here. She can follow that. Thank you.
I just want to share my screen. So for example, let's give a name. So I just called it systematic review. Let's, for example, does aerobic exercise decrease systolic blood pressure in adults over 60? For example, and we'd have our description. Uh, just a minute. So here you'd have to enter your search. Uh, I'm not that familiar with mesh terms, to be honest, but the idea is that you add all your terms here, and like for example, hypertension, uh, What else could I add? A little bit. Of it. Uh, and then so doctor, to be honest, I'm not familiar with the mesh terms, but the idea is that you add your terms here and then you add them with the mesh terms and then you come out with a search.
Sounds good. Sounds good. I just want
Right.
to let the fellows know how to just look at the website and add their search.
Right, it's very user friendly. It just like I might have overstated how much you need, how little experience you do need, because you do need to know a lot of the mesh terms, which I currently don't know. But the idea is that you add the keywords, your mesh terms, and then you can get a good search afterwards.
Sounds good.
Right.
Thank you so much. If
Thank you everyone for listening. Also, I hope it wasn't long or boring.
no, it's very useful. Thank you so much, and we'll
Thank
go
you.
to the next topic. If no more questions, Dr. Abdullah, when you are ready, you can go ahead and
Okay,
followed by
sure.
Dr.
Just
Alaa.
1 second. I will check my present. Can you see the slides? Great. Assalamu alaikum, everyone. This is Dr. Abdullah Satti. I'm a recent medical graduate from the University of Jazeera, Sudan, currently a classified general practitioner based in Saudi Arabia. And I'm happy to be presenting today for the second time in the TGRF Research Fellowship with the red team, I'm sorry. I should have been here earlier because I should have been moderating this session, but unfortunately I was late. I didn't know the meeting would start at 9 p.m. my time. But thank you so much, Dr. Nadra. Thank you so much, Dr. Amr, for the great presentation. It was actually very nice, at least the part that I attended. So moving forward to the next topic from the red team, we would be talking about the pressure ulcers, and we would also be navigating through prevention of the pressure ulcer staging and management. So as a starter, this slide contains the objectives of the session, which is first understand the pathophysiology and risk factors of the pressure ulcer, and as well as apply a validated risk assessment tool. We should know that who or which patient would get pressure ulcer and which one wouldn't. We also would navigate the staging system and see some prevention strategies, inshallah. So what a pressure ulcer is, or a PU is. So an ulcer is a localized injury to the skin. So it's mainly a skin problem. A localized injury to the skin, second, because I cannot see it. Or the underlying tissue and the underlying tissue. It usually occurs in a bony prominence as a result of friction, or the friction combination of shear forces and friction. I will explain this in a moment. But first, let's look at the epidemiology. So pressure ulcer is a very common, or PU is a very common medical problem. It's prevalent in the community, in the long-term care facilities, as well as the hospital. So a case of from the community is, I remember when I was an intern, we had a very, or like not an elderly patient, 59 years old, female, long case of hyperlipidemia, presented with pressure ulcer in the sacrum. But why? Because she was very obese to the extent that she could not walk without crutches, and she used to walk from one place to another using only wheelchair. So for a long term, this caused her pressure ulcer in the sacrum. So it's prevalent in the community. The patient characteristic could identify which one could have these ulcers. So a key point is that 95% of pressure ulcers are preventable, which puts it in a quality indicator of hospitals. Like if many patients in the hospital are having pressure ulcers, this means that there is a problem with patient care in this hospital. And another thing that I should point out is most pressure ulcers are preventable. However, the rest of the 5% who get pressure ulcers are either having hemodynamic instability, like patients with septic shock, ICU, hypoperfusion to the tissues cause less blood flow to the skin, and it results in pressure ulcers. Patients also with terminal illness who have like no other decisions made about their health, as well as essential medical devices. If you are putting a ventilator in your nose, you would be susceptible to pressure ulcers. Okay, so let's explain the pathophysiology of pressure ulcers, why pressure ulcers develop. There is something called the capillary closing pressure, which is the pressure in the capillaries that needs to be present for the blood to flow through the capillary. If there is a pressure from the outside exceeding this capillary closing pressure, which is 32, the capillary would close. If it closes, no blood flows to the tissue. If no blood flows to the tissue, there happens the ischemia and the hypoxia. And the result is cell death and necrosis. It's very simple, very logic, very common sense. And we should be able to understand the consequences of long-term pressure applied to patients, like those resting in the ICU beds in the hospital for long term. And the contributing factors, as mentioned, is shear forces, friction, is moisture. So how does moisture contribute to developing pressure ulcers? Is like just imagine you have two tissues. One tissue is dry and one tissue is wet. And just look which one would tear easily. It's definitely the one in the water or the one that's moist. We should also note that pressure ulcers will occur even before the skin breaks, meaning that if you come and examine a patient for a pressure ulcer and did not see a skin breaks, this doesn't mean that this patient is not susceptible or is not developing pressure ulcers. It's just progressing, and this would lead to better patient care. So talking about the risk factors, especially in geriatric patients, number one is immobility. Immobility is the main cause of pressure ulcer because our body is heavy, and when this heavy body attaches to bed most of the time, this creates pressure on sides of the body. This pressure closes the capillaries, and the closure of the capillaries leads to decreased blood flow to the tissues, which, as mentioned before, leads to tissue ischemia and tissue hypoxia. Who are those patients? Those are the ones bedridden, the wheelchair-bound patients, and the stroke patients, because as mentioned before, the pressure closes the capillary. Another category is those with sensory loss, especially those with diabetes who have neuropathy. They step on things or use their feet, let's say, or even the pressure ulcers are painful. Those who lose the sensation of pain wouldn't recognize that there is something or there is issue. So definitely they're gonna be among those who develop pressure ulcers. The third one or third category is those with incontinence, either urinary or fecal incontinence, because this leads to moisture of the skin, as well as those with malnutrition, because the skin integration becomes very weak due to low protein, due to dehydration, due to weight loss. And people with comorbidities are susceptible to develop pressure ulcers due to collective risk factors, beginning from immobility, from sensory loss, and even sedation, because as we know, if you are a sedated patient, you do not move very well, or you cannot mobilize yourself. So this immobilization leads to increased pressure and pressure ulcer at the end. So in order to understand which patients would get pressure ulcers, we have something called risk assessment tool. This is a tool that is applied to patients in order to detect which patient is at risk, either mild, moderate, or severe, and which patient is not. So scale we have or we use is the Barden scale. It has 6 subscales containing the sensory perception, the moisture, naturality of the patient, the activity, the mobility, the nutrition, and the friction. It's a total of 23 points. If the patient gets a score of 16 to 15 points, there is a mild risk that this patient is going to have a pressure ulcer. And if it was less than 11, this is a very strong indicator that this patient is going to have pressure ulcer. For example, if the sensory perception is very low, you give a point of 1. The activity is very low, you give a point of 1. The mobility is very low, you give a point of 1, and so on. So before we go to the staging, we first need to understand the normal anatomy of the skin. The skin contains, or the pressure ulcer anatomy contains 4 main components, which the epidermis, dermis, the fat, and the bone. Whenever disintegrity happens to this structure, we would stage the ulcers either 1, 2, 3, 4, or even unstageable. So let's move forward and see staging. So the first stage is an unblanchable erythema. There is just an erythema. So how can we call this an ulcer? Because as mentioned before, intact skin doesn't mean that there is no pathology going on. There is some pathology going on, and we need to recognize that and to act immediately. So in stage 1, the skin is intact. There is no breaks, but there is erythema. And when you press on this erythema, you would expect that this blood would go and fade away and the skin would turn white. But in stage 1 ulcer, the erythema does not blench. So this should tell you that there is heavier pressure put on the capillaries of this patient, and you need to act immediately. And in darkly pigmented people, the black skin people, this redness would not appear as redness, either it would be purple or blue discoloration. So you need to also put your mind to that. The second stage is partial thickness skin lesion. The thickness here is the thickness of the skin, the epidermis and the dermis. So at this stage, the epidermis is breached. So this is a progression from stage 1. And the dermis is exposed. As you see in this picture, here is the surrounding skin, and here is the epidermis beneath the, here is the dermis beneath the epidermis. And the wound is pink. There is no like this yellowish discoloration, and there is no sloughing. It's a pink red viable wound. And the most important thing to know about stage 2 PU is that there is no visible fat, because if the fat is visible, this is no longer stage 2. This progresses to stage 3. We should also put in our mind that patient would be in pain because the nerve fibers are exposed, and management should consider pain management as well. So stage 3, after breaking the epidermis and the dermis, there is the subcutaneous fat. As we saw here, this is the epidermis, this is the dermis, this is the subcu fat. And why this is important? Because in elderly, the subcutaneous fat is atrophied. So their susceptibility to get an advanced ulcer is very high, and we should pay attention to that. So full thickness is the loss of both epidermis and the dermis. The subcutaneous tissue is visible. You would see the yellowish discoloration of the skin of the patient. But a very important differentiator from stage 4 is that you don't see bone, you don't see tendons, you don't see muscle. If you see those structures, this is no longer stage 3, this is stage 4. And what you could see also, you could see sloughs, like regenerating tissues, but you should not see bone or tendon. If you see bone or tendon or muscle, this means that this is stage 4, and this is full sickness, loss of soft tissue. The skin has already been breached, the subcutaneous tissue has already been breached. Now the muscle, the other structures are visible, and there is a risk of osteomyelitis in these patients. So this is a picture that shows all the stages of the ulcer. This is the epidermis, stage 1, only erythema. This is stage 2, reaching the epidermis and the dermis. Stage 3 has gone through the fat layer, and stage 4 has reached the muscle and the bone of the patient. We need to also recognize that the bony prominences are very susceptible for pressure ulcers. And why is that? Because if you think about it, if you put your hand right now on a table and press on that table, you would feel little pressure on the hand. On the other side, if you put the prominence of your finger on the table, the same power, you would notice that the pressure is even higher. This is exactly what happens in bony prominences of the body. The sacrum, the heels, these places have less cushion of subcutaneous fat, and especially as we mentioned before, elderly patients, they have atrophy of the fat cells, and stage 4 ulcers could be happening more in these patients. Okay, let's go to the prevention. The prevention of these ulcers, as mentioned before, is like 95% achievable, and it's very simple. We need to understand that pressure for continuous time, like a patient lying on bed for more than 10 hours without mobilizing the patient, would compromise the blood supply to these areas. Why? Because if the pressure was mild, let's say about exceeding the closing pressure with 10 millimeter of mercury, this needs a long time for the patient to develop an ulcer. However, if the patient is lying, which the literature says, if you lie in bed, the pressure on capillaries is 100 millimeter mercury exceeding the closing capillary pressure. This would make the patient develop ulcer very soon. So you need to reposition the patient every 2 to 3 hours in order to restore the blood supply to this area. You also need to make sure that your patient have proper support surfaces like the pressure redistributing matrices and the cushions that you usually see in the hospitals. We need to also pay attention to the skincare of the patient as well as good nutrition. And most importantly, if the patient is not hospitalized, if it is not engaging with healthcare for a long term, you need to educate the patient himself, or you need to educate the caregiver about these issues. And as we know, prevention is much, much, much better than cure. It saves lives because the consequences of pressure ulcer could be very devastating, including the osteomyelitis itself, which could progress to sepsis and septic shock, and the patient could die from a very preventable medical condition. So in terms of management, we have two fixed components of the management. Every patient with an ulcer should have these two components, which is cleansing. You should wash this ulcer with normal saline, and you should also provide debridement of the lesion. If it's necrotic, if it's have any issues that needs action, you should do that. And for the long term of the treatment of the ulcer, you need to put a hydrocolloid or foam dressings if the ulcer was stage 1 and stage 2. And if it was stage 3 or 4, we need to use other forms of dressings, which is called hydrofibers. And we could also use negative pressure therapy, these ones. Most importantly, you need to prevent the infections. There are some dressings containing antibiotics as well. If you suspect that this patient is having an infected ulcer, you should treat the patient with proper antibiotics and also apply the appropriate dressing. So the references from the presentation is 1, 2, 3. You could look into it later on the presentation. And thank you for your time and listen. If you have any questions, ask me.
Thank you so much, Dr. Abdullah. If there are any questions for Dr. Abdullah, please go ahead. And I think it's a very important topic that people know how to prevent, as Dr. Abdullah mentioned. If no more questions, we can move on to the next topic. If Dr. Alaa is here. When you're ready, you can start, Dr. Alaa Khalifa.
Hello, everyone. Yes, I am here and ready.
Go ahead. Thank you.
So, hello, everyone. Thank you so much for having me today. Today, I want to talk about an important subject, which is AI in medicine, not as a buzzword we throw around in conference, but as something that's already actively reshaping how we practice right now in real health system with a real patient. So I will start with a quick map of where AI already sits across the healthcare landscape, because I think most of us underestimate just how broad it already is. It is far more than chatbots and image reading. Then I will dive into one concrete, very current case study by Google DeepMind's AI, which is called Clinician, and walk through exactly how it works, what is genuinely good at, and just as importantly, where it is still falls apart. And I will close with the part I think matter most to us personally, not what AI can do in the abstract, but what we as a physician should actually be doing in response. Practical step, not the vague encouragement to keep up in AI. So healthcare has a has a tradition reactive. You get sick, you come in, we treat you. AI is pushing it toward prediction and prevention, which is connect isolated hospital into shared ecosystem, replacing manual workflows with intelligent system and easing the documentation load that eats up so much of our day. So keep these four shifts in mind. the reactive care, isolated hospitals, manual workflows, and documentation heavy, and how AI assists us with all of this, because I will show you يعني specifically for each one of them how AI can help us. So AI landscape, clinical and diagnostic layer. AI in medicine isn't one thing, it is a whole landscape. Clinical decision, support, help with diagnosis and drug interaction alert, diagnostic and imaging AI reads X-rays, CT scan, ECGs, skin lesions, retinal scans. Generative AI writes our discharge, summarize and note. NLP powers transcriptions and chatbots. Predictive analytics flags sepsis and ICU deterioration early. And remote monitoring, wearables, biosensors extends our reach into the home. I will come back to the last one because specifically it's relevant to our project in telegeriatric fellowship. So beyond the bedside, AI run the machinery behind healthcare too. Operational AI manage bed allocation and staffing. Financial AI catch fraud and automates claims. Robotic AI shows up in surgery and pharmacy automation. Precision medicine AI personalized treatment through genomics. Drug discovery AI accelerate finding new molecules. Public health AI track outbreaks and vaccination coverage. Uh, and uh, and uh, and AI connected fragmented EHR system, and federated AI lets hospital train shared modules without moving patient data offsite. All of this is already running in real health system right now. So now let's spot the light in predictive and remote monitoring AI. Now, everything I just listed, two categories matters more than the rest of what we specifically do in this fellowship: predictive and analytics and remote monitoring. Predictive modules are already catching sepsis, ICU deterioration, and disease progression before the clinical picture becomes obvious. And in geriatric population specifically, where deterioration is often subtle and atypical, that already warning window is frequently the difference between the outpatient intervention and hospital admission. Remote monitoring is the other half of the equation. Wearable and biosensors effectively turns a patient's home into an extension of a clinic. For our elderly patient, this translates into very concrete benefit: catching a full risk and arrhythmia or functional decline before it turns into emergency room visit, and extending a specialist reach into a home or nursing facility they may never physically visit. This is quite literally where telegeriatric and medicine AI intersect, not as abstract trend, but the infrastructure our field is being built on. So now let's talk about the case study, AI co-clinician. Now I want to ground all of this in one very current, very concrete example. On April 13 of this year, Google DeepMind announced a research initiative called the AI co-clinician. The central AI is something they call triadic care. In traditional medicine, care happens in a pair, physician and patient. Triadic care adds a third party into that relationship, an AI agent that sits alongside both of them, observing, assisting, contributing, but critically not replacing either party. The physician returns full clinical authority. The AI functions as a genuine member of the care team. Operating under supervision, it's worth understanding why DeepMind chose this framing rather than pursuing fully autonomous AI doctor. The World Health Organization project a global shortfall of 10 million health workers by 2030, concentrated heavily in underserved and rural regions. DeepMind is positioning this technology as a way to extend physician capacity into that gap, not to eliminate the physician from the equation. So now let's talk about how all of this work. This system didn't appear out of nowhere. Nowhere. It's the product of several years of carefully validated research, and I think the line is worth walking through because it shows a real scientific rigor than a sudden leap. It started with the mid-palm, the first major proof point, which demonstrated the large language module could pass medical licensing style exam question, establishing that these modules could actually help and reason over structured medical knowledge, not just pattern match next. The next milestone was AMI, the Articulate Medical Intelligence Explorer, which went further and matched physician-level performance in stimulated diagnostic consultations, later validated in real-world feasibility trials, not just controlled lab setting. AI cognition is the next chapter, and the key technical leap built on Gemini reasoning capabilities and Project Stra's live perceptions technology. It can process live audio and video in real time, not just text in stimulated telemedicine setting. It has demonstrated the ability to actually observe a patient movement and guide them through a physical examination maneuver, for example, demonstrating correct inhaler technique or walking someone through a shoulder mobility test live over video the way a physician would if they were in the room. So let's talk about what the early results show right now. So because I think it's important to look at a real number rather than marketing language, in 1980, realistic primary care scenarios evaluated under something called the NOHARM safety frameworks. The system had 0 critical errors in 90-70 of them. A genuinely strong safety, a single of the first generation system. In a study published in Nature Medicine across 140 consultation area, the AI co-clinician actually outperformed primary care physicians in 68 of them. And earlier, AMIE research, it beat physician on diagnostic accuracy in 28 of 32 of evaluated quality dimension. It's also been tested on open FDA's benchmark for medicine reasoning, showing meaningful progress on open-ended clinical questions. And in blind evaluation, physicians actually performed its output over existing evidence synthesis tools they currently use. Now, I want to be clear about this because it is the most important part of this section. Physicians still lead in 3 areas: physical examination findings, communication, and clinical judgment under high pressure. Exactly the messy under-specified situation that don't show up cleanly in benchmark. Deep mind, them are intended to augmentate physician authority, not as a replacement, and that current collaboration are not intended for actual diagnosis or treatment decision. That distinction matter, and I think it's the right place for the technology to sit right now. So let's bring this back to what it actually means for the work we do. First, remote exam, because genuinely richer live video and audio AI can guide a caregiver or the patient themselves through a physical maneuver at home, which start to close a real long-standing gap in telemedicine quality compared to an in-person visit. Second, we get earlier deterioration signals. Predictive analytic layered on top of wearable data can flag functional decline or fall risk well before it turns into crisis visit or hospital admission. Third, our documentation burden goes down. Generative AI and NLP tools can absorb a huge share of transcription and summarization work, which give us as fellows and clinician more actual time for a direct patient contact instead of typing notes. And fourth, the patient I want to underline most strongly, human oversight stays absolutely central through all of this. Even every system I have described today is built and marked as a decision support, operating under clinician authority. The physician retain the responsibility, retain judgment, and retain the final word. So where is this heading? Zooming out from geriatrics specifically, here is where the border field is heading over roughly the next 5 to 10 years. We are moving toward AI native hospitals built around these tools from the ground up rather than bolted into legacy system. So AI that listen and documented passively during a visit without anyone actively operating it is already in early deployment in some system. Digital twin healthcare is an emerging concept where a patient physiology is simulated virtually, so interventions can be tested before they are applied to the real person. Federated national healthcare AI would let entire health system, even entire countries, train shared modules, collaborative while keeping patient data local and private. We are also heading toward more autonomous workflows for routine operational tasks and preventive population scale health. AI that shift entire health system from reactive treatment to proactive prevention at scales. The message I want to leave you with here is simple. AI in healthcare is no longer just a tool that sits on top of medicine. It is becoming foundational healthcare infrastructure. It's in much the same way to electronic health records become infrastructure 2 decades ago. Nobody asks anymore whether a hospital uses an EHR. Within a decade, I suspect nobody will ask whether a hospital uses AI either. So given everything I have just walked through, the natural question is, what should we do? Personally, actually, be doing about it. I want to give you 6 concrete things, not vague encouragement to stay current. 1, build real AI fluency. This means genuinely understanding what these modules can and can't do, how they are trained, what hallucination risk looks like, the basics of how validation works, not just knowing which button to click. 2, protect the human edge. Double down on physical exam skills, communication, and clinical judgment because that is where we still outperform every system I have shown you today. And that gap is our actual professional value going forward. 3, get involved in validation research. Someone has to build the evidence base for all of this, and clinicians, not engineers alone, are the ones best positions to do it. Contribute to clinical ground truth. So for practice human AI teaming, use AI as a second opinion or co-pilot, never as final answer, and get comfortable with workflow like the triadic care module where the physician retain authority. 5, champion safely and governance. Push actively for data privacy protection, informed consent processes, bias auditing, and clear error reporting channel wherever AI touches a patient care in your own institution. And 6, commit to continuous learning because this field is moving faster than a traditional SME cycle, and treating it like a fast evolving subspecialty rather than a one-time training module is the only way to keep pace. So to make those 6 principles concrete rather than aspirational, here is a simple 3 horizon roadmap. Right now, today, starting AI tools critically in your daily practice for documentation, literature synthesis, coding support, but build the habit of always verifying the output before it touches a patient chart or influences a clinical decision. Over the next 1 to 2 years, invest in building a real data and informatics literacy, and actively look for an opportunity to join or even lead an AI validation study within your own specialty. The goal is to be able to read modules, validation data, the way you already read a drug package and cert with the same critical eye. And longer term, over the course of a career, aim to be in the room where this actually gets governed. Sit on the institutional AI governance or ethics committee, contribute to clinical guidelines as they are written, and mentor the trainees where are going to inherit a field that looks fundamentally different from the one we trained in. This isn't optional career anymore. I would argue it's because becoming part of what it means to practice medicine going forward. So thank you so much. So it's bring all together. AI is moving medicine from reactive to predictive, from isolated system to connected ecosystem, and from documentation heavy workflow to AI native platform. So thank you very much. I would be glad to take any question.
Thank you, Dr. Alaa, for excellent presentation. Any questions for either Dr. Alaa, Amr, or Abdullah? Please go ahead. If no more questions, I'd like to thank you all for your excellent presentation, all of you. You did great. Thank you so much. We can move on to the next topic. If Dr. Nabiha is here, please go ahead.
Hello, Dr. Nader. Hello, everyone. I hope everyone is doing good. So I have my topic ready. Let me just share my slide and we can begin. Okay. So can everyone hear me?
Yes.
All right. I'm not sure. Just a minute. I think is my presentation visible on the screen, because I'm seeing something else on the screen.
It is visible.
Okay. Sure. All right. So our research topic for today is the presentation topic for today is the research consent, and we need to understand that when we talk about consent, what kind of consent are we talking about? So it is the informed consent for the clinical research. And what exactly is the informed consent? So it is a structured process in clinical research where participants voluntarily confirm their willingness to participate in a study after they fully understand all the relevant aspects, including all the risks, benefits, and the procedures. And it is an ethical obligation and a regulatory requirement under ICH GCP R3. And we need to understand what exactly is ICH GCP R3. So it represents the most profound modernization of the clinical trial frameworks in over 25 years. So now, when do we really need the informed consent? So whenever we are doing a research that involve humans and people such as patients, children, incompetent, incapacitated persons, healthy volunteers, immigrants, or any other humans that are involved, we need this informed consent. And when the research uses or collects human genetic material, biological samples, or personal data, in that scenario, we need the informed consent as well. But there are few instances or circumstances where the consent may not be required. However, number one, the criteria for these circumstances and conditions is very strict. Number two, the IRB approval needs to be there before we decide upon not to take the consent. And what are the three conditions? So number one, it is impracticable to obtain the consent. Number two, the research does not infringe the principle of self-determination. And number three, the research provides significant clinical relevance. So mostly in cases where there is some emergency situation where we need to perform the research, but then it is very difficult to take consent from the patients right there and then, maybe because the patient is unconscious. That is one of the few conditions that can qualify for us to not take the consent, but we still need IRB approval, and we need to follow the strict criteria before we finally decide about not to take the consent. So, what should be the environment in which we take the consent? So, first of all, we need to know that all the information provided with regard to the consent should be either by the physician or any other researcher of that research with appropriate scientific training and qualifications. This is very necessary because we need to make sure that the participant understands. All the risk benefits, all the procedures, and he can make a well aware decision. And the other important thing is that the participant's physical, emotional, and psychological capability must be taken into consideration when taking the consent. So, why do we really need to take the informed consent? So, number one, it protects the right, safety, and well being of the participants. It ensures the transparency and ethical conduct. It builds trust between the participants and the researchers. It supports the regulatory compliance and study credibility, which is very important with regard to our ethical consideration of the research. And when we talk about the informed consent, we also need to take into account the vulnerable populations that are there. So, who are the vulnerable populations? These are the disadvantaged community subgroup unable to make informed choices, protect themselves from inherent or intended risk, or keep their own interests safeguarded. So there are three kind of vulnerabilities. Number one is the physical vulnerability. Number two is the psychological vulnerability, and then we have the social vulnerability. When we talk about the physical vulnerability, we've got pregnant women, fetuses, children, orphans, students, employees, prisoners, the military people, and those who are chronically or terminally ill. Then we come to the psychological vulnerability. So, any cognitive or intellectually impaired individuals. And then we have social vulnerability. So, homeless people, people from ethnic minorities, immigrants, refugees. Several ethical dilemmas often arise when we are having these populations as the research population of our research, and we need to ensure and guarantee that there's protection of rights, safety, data privacy, and confidentiality of these vulnerable subjects. And once we do it, that would ultimately mean a good clinical practice, and that would be something that would be ethical with regards to research protocols. And also, even though we're not going into very detail about the protocols of dealing with the vulnerable populations, they have their separate criteria that need to be met in order for the research to be carried out in these vulnerable populations. So, what are the key elements of the informed consent? The first and the most important thing is to identify the purpose of the study, then to the study procedures and durations that need to be mentioned, potential risk and discomforts. If there's any incidental finding during the research, how would that be handled? That should be told to the participants. Expected benefits, alternative treatment which are available, confidentiality of records, compensation and medical care if applicable, and voluntary participation and right to withdraw. This is very important, and the participants must know and should be told that it's a voluntary participation and the participant always has the right to withdraw. So, what is a process of taking the informed consent? The first and the most important thing is that the investigator ascertains that the participant or the individual has a decision making capacity. Then the participant receives the informed consent document. Investigator explains the study in simple, understandable language. Participant is given time to ask questions. Adequate time is provided for the decision making. Written consent is obtained before any study related procedure, and a signed copy is provided to the participant. And when we talk about informed consent, there are few responsibilities on part of investigator, participant, and the ethical community (IRB). So, when we talk about investigator, the investigator has to ensure complete and clear explanation of what the research is about and all the protocols and everything that we talked about in the key elements, and avoid the coercion or undue influence. So we have to make sure that the participant is not overwhelmed and is not being forced into participating, and that if he or she participates, it's only voluntarily, and confirm the participant's understanding. With regard to the participants, so the participants should ask questions and seek clarification about any query, anything that he thinks is important, and make an independent and voluntary decision. Then we come to the ethical community committee or IRB. So review and approve the consent documents, ensure the participants' protection. So while taking the informed consent, there are few mistakes that need to be avoided. Number one, avoid using complex medical jargon because we don't want to confuse the participants. We don't want to overwhelm them. Rushing the consent process. So the whenever we take the informed consent, it has to be very calm environment so that the patient understands everything, is able to make a well-informed decision. Missing signatures or dates because once anything that is not written is practically not there. So we have to make sure that everything is written properly. All the written things are ensured and all the signatures are done. All the dates are properly mentioned. Not updating the consent after the protocol amendments, and incomplete explanation of risks. So this is also very important because every participant has a right to know all the benefit, risk, and any other thing that is important before they make the final decision. So the major takeaways from this presentation would be that respect for people is the foundation of ethical research, and then informed consent is not just a document; it is an ongoing communication process throughout the study life cycle. And as researchers, we must keep these both things in mind to have our research very ethical and according to the protocols. These are the references that I used. And thank you so much. If there are any questions, I would love to answer them. Thank you.
Thank you so much, Dr. Nabiha. This is also excellent presentation. Thank you.
Thank you so much, Dr. Nader.
Any questions or any comments from the group here?
I just have one question. If you would mind.
Go ahead.
Thank you so much. Thank you so much, Dr. Nabiha. My question was, like, when I was in the at university times, we had to go to the rural areas and collect data from them. And when I was collecting the data from the rural residents, I did not I wasn't sure if they are giving consent as a consent. They were just saying yes, let's do the interview and such thing. Is that considered the consent? Because sometimes people do not understand they are giving consent. They are just saying yes. And how can we deal with this?
That's a very good question, in fact, because I think during my med school, I also faced the same situation because we are talking to residents, they're saying yes, yes, but they're not even listening. So in that case, what I can just talk about my experience that I tried my best to, at least from my side, tell them everything that is important for them. But this really needs a more clarification as to how should we deal such situations because they're seniors and they're saying yes, yes, and we don't know what to do next because we are trying our best, right? So maybe Dr. Nader can help us better in understanding how to deal with such situations.
Yeah, it's an excellent question, and as you mentioned, so it depends on the population at like the risk, or the idea is to get the consent after they understand all the project from A to Z, including the risk to them and benefit, and why you are doing it for your own benefit. So here in the US, this is supposed to be a document, and the participant will sign that document. So the researcher will go over the point that you just mentioned, and actually you need this document sent to the IRB before even you talk to the participant. And so the IRB is supposed to go over this, and if you are missing any part, they will not approve your study until you provide a full, completed document that will prevent any harms to the participant. In our countries, however, in other places, most of the older population may not be educated or able to read. So in these communities, I think the best option is to involve them, speaking to them, making sure they understand why you are doing this, and explain to them if there is any risk, and explaining if there is any benefit, and see if they can agree to participate, and show you they understand what you said. So here in the US, we say, give me feedback what I said. So when you see a patient, you explain the medication you are going to start and side effects and so on. So you try to understand if the patient will reflect or will give you their understanding. So it goes the same way, where you will explain to the participant the study, why you are doing it, what you expect, and what you want from them, and what the risk, if there is any risk to them, what the benefit, if there is any, and then let them reply to you with what they understood. So if they repeat exactly what you said, that means they understand at least what you are talking about, and then you can get their approval if they want to proceed, and they can change their mind in the middle if they want to. And if they say yes, you can just mention that in the document that you explained, and they repeated what you told them, and then you get the approval from them. Then you proceed. But the whole process is supposed to be in place to prevent the harm of this participant, if that makes sense. Thank you.
Thank you so much.
Thank you so much, Dr. Nadir. And you said it so rightly that documentation at the end is the most important thing, because that is the evidence that you did what you said you did, right? So it all at the end of the day comes to proper documentation, and that is very important when when we talk about consents and researches.
And as you mentioned in your presentation, that the consent itself, they need to be signed, and you give a copy to the patient, and you keep copy for your record in case you come across auditing. They can review your documents, including the consent forms that we have from participant. Thank you.
Thank you so much, Dr. Nadir.
If no more questions, we can move on to the next section. So we are open for any comments or updates. Please go ahead if you are working on a project and you want to give us an update. I think Dr. Malas, go ahead.
Hello, Dr. Nadir. Hello, everyone. Thank you so much, Dr. Nabiha, for your great presentation. Thank you, Dr. Amr, Dr. Abdullah, Dr. Alaa. You did a
Thank you,
great
Dr. Malas.
job, actually. Thank you all. Okay, actually, my update, Alhamdulillah, our military medicine project submitted successfully, and our pediatric project even so submitted successfully. I contacted even so the journal regarding the if like the abstract accepted and so on, because like to find someone, I think in Greece it's very difficult as presenter. And then I tried even so to reach out for the like conference team, organizer team, I mean, and I contacted them and told them that okay, can like select just for example the e-poster if our abstract presented accepted. Can we present it as online e-poster, and if accepted even so we're gonna be given opportunity for like publishing in journal and so on. And yeah, alhamdulillah, they contacted me back and told me the best way to select the e-poster, and they will give us the opportunity for the online presentation inshallah if accepted. And yeah, alhamdulillah, even so like for the emergency regarding the dementia and so on, we finished the data extraction, alhamdulillah. So right now I'm starting actually the abstract writing. Dr. Nabiha and Dr. Mohammed will gonna join me even so in abstract writing. So inshallah we are planning to submit it. And even so I'm starting writing the manuscript for the mobile app, and inshallah we're gonna submit it to the journal. So after finish, we're gonna send it for your approval, Dr. Nadir, inshallah. So yeah, even so, Dr. Nadir, we started the COPD project, alhamdulillah. What happened, Dr. Nadir? Actually, I want to apologize for something. I make a new project sheet because I tried to edit your own sheet, but I felt suddenly like, oh, getting confused. Oh, everything is starting to be messy and so on. Oh, okay, what I did, what I edited. Okay, then I couldn't even so like feel what I'm doing right now. So I did a new project sheet based on your all your documents and so on, based on all your resources. And I gave you even so an access. I'm sorry, Dr. Nadir, but alhamdulillah, everything is right now going good. Even so, I recorded the video for the team because mostly of them actually new fellows and so on. I told them about the project, the research question, our gap and so on, our goal. And even so, I told them how we have to work and so on because working in like new, you can say origin project, not same to like the systematic review. I told them how we have to um, review the apps and so on and do data cleaning because this is a very important point and we should do it very carefully because our results dependent highly on it. So our first step, we should do it with all of accuracy. So I told them how we have to do that. So right now, actually, we are starting. Dr. Alaa will gonna be a project leader. Dr. Mohammed will gonna be co-leader, inshallah. So we're gonna proceed with data cleaning, reviewing, and so on. And then we're gonna do data extraction. So our plan, inshallah, to submit for chest. I check chest guidelines conference. So they asked that even so the abstract should be mentioning the clinical implications, the methods, and so on. I think they have a specific guideline for that. So based on that, inshallah, we're gonna submit our abstract to it specifically, and we're gonna edit it, inshallah. We're gonna keep you updated. We're gonna submit it for you, Dr. Nadi, for your approval, inshallah. So our deadline, I think, on August. So we have a time. We have to work on it actually carefully. I like this project. I feel it's very good, or you can say excellent project. Really, I'm so interested regarding this project. So inshallah, it's gonna be great. Inshallah, we're gonna win. Inshallah, we do it with all accuracy, you can say, and our results are gonna be high relevant. Yeah, that is about COPD. So yeah, even so, Dr. Nadir, I noticed another project. So I want to ask you if this project is submitted for the RCB or not, because suddenly I found it when I opened my Google Sheet. Let me just share my screen, Dr. Nadir. I'm sorry.
Right.
Mm, I think it's here. So this project, Dr. Nadir, I don't know about it actually. Suddenly I found it and I found my name here even so. Where is others? Yeah, here. I don't know like about the project. I don't even saw like someone added me to it. I don't know about if this project like not completed. We can see it. We can work on it. We can see if anyone actually want to be a leader for it, and it can help him because it's a grade actually. It's about the teaching clinical reasoning to international medical graduates. So I don't know Allah, Dr. Nadir.
Yeah, I think we created different sheets like this in the past, and maybe people were interested and then they did not proceed for one or more reasons. So my suggestion is to look at the list of the authors and contact them, see if any started and how, if they did, far they went. If no one started, then as you mentioned, you can identify someone who is interested to lead the team. If these people listed are interested, they can participate, taking some task. If they are busy or not interested, then maybe you can add more to the team, or the leader can add more fellows to the team, and then identify the task and then see where we can go with this. Yeah.
Okay, inshallah.
Great. Yeah. Thank you.
Thank you so much.
Thank you so much for the update. Anyone else would like to update us? Anyone is working on one or more projects? Please go ahead and tell us what you are doing. And if you are not, maybe you can tell us what you are interested in, what area, what you want to do, and maybe we can come up with some projects for you guys. So anyone has ideas?
Hello, Dr. Nadir.
Hello, Dr. Asma. Yes, go ahead. Sorry.
Yeah, no problem. Just I want to present my topic, bridging the gap, please.
Yes, please go ahead
Okay.
when you're ready. Thank you.
I will connect with my laptop.
Yes, take your time.
Hello, now I'm sharing my screen. It is clear now. This poster is bridging the gap.
Yes.
Yes, so hello everyone. So I would like to give you a simple idea about our project. So our project is bridging the gap. This is an audit of simplified dementia care resources. Our aim from this project to assess whether AI tools can make dementia information easier for patients and their caregivers to understand. We evaluated three large language models, which are GPT-4o, Gemini 1.5, and DeepSeek 3.2. We asked all these models to translate professional dementia care information into patient-friendly language. And we found that these models can make dementia information easier for patients and caregivers to understand. And while maintaining clinical, however, we found some generated responses too clinical or lack empathetic tone. So overall, we concluded that AI tools can be useful and help in simplifying dementia care information. However, their use should be always reviewed by clinical health professional before being used by patients. Because sometimes can generate responses which is lack empathetic tone. So this is a simple idea about our project. Thank you, everyone.
Thank you so much. Any questions or any comments, any advice, any tips, any feedback? I think you did great, and it's concise to the point, and
Thank you.
mentioned the method and what the goal, and you did great.
Thank you, Dr. Nadia.
Sometimes you might get questions. One of the questions might be, so you reach this, what the next step, or what's your future? So in this, if you look at the future direction, you will mention that we have identified 3 areas where we can jump on the near term, and we want to do this, or we want to. So it's listed here for you.
Yeah.
So
Okay.
it depends on the question.
Yeah, okay. Thank you, Dr. Nadir. And any advice or any other tips, please?
As far as from my side, I think you did great. And if you continue to practice, it's going to be easier for you to just verbally and maybe using your body language when you are standing in front. And that's it. As I mentioned last time, be confident. You are on top of this. You are the expert. So everyone coming to you, it's going to be like 5th grader or 3rd grader in middle school. They just want to learn from you, because it's a new thing, and not everyone is on
Okay,
this.
thank you.
Thank you. Yeah.
Thank you, teacher. Another question regarding the dates for our in-person presentation. Did they send us the schedule for our in-person presentations?
So on the 12th, they mentioned in the email that or the website, but what I suggest is you contact them. I think they have a phone number. If you don't mind, call them.
Yeah, of
ask
course,
them,
yeah.
and give them the ID number of the abstract. Mention to them that you have 2 abstracts. You are going to present what days the judge will come and because I think they will divide the abstracts to themes, and each theme will be different days. So
Yeah. Yeah, of course. Yeah. I will contact them. On Monday.
all
Okay.
right, sounds good. Excellent.
Thank you, Dr. Nader, and thank you everyone for listening.
Good.
Have you even watched any of my channel?
Any other updates or any other questions? Any ideas?
Dr. Asma, thank you so much. Actually, you did a great job. Even so, you don't know how much I liked your post project. Actually, very strong project. Inshallah, we're gonna win. We're gonna do a great job. I trust you. Inshallah.
Thank you, Dr. Nader.
Let me ask you a question. Just like
Okay,
put you
of course,
like
yeah.
in stress. Yeah, something like what I felt when they asked me. Okay.
Okay,
So,
yeah.
how can we make sure simplification does not accidentally reduce clinical accuracy or remove important medical nouns? What do you
Uh,
think?
so just a minute. Sorry, Lina. Sorry, Dr. Nader. Just a minute.
Yeah, okay, take your time.
Yeah.
So I'm
With
gonna
my
jump.
little girls, coming here, but yeah, I'm here. So you asked how we make sure that the information generated by AI tools will be clinical
Yeah.
accurate. Yeah. So we assessed output for clinical accuracy using a 5-point Likert scale, and so the
Mm-hmm.
result that the accuracy is scored 4.5 out of 5. And this,
Mm-hmm.
I think, this is high, I think it is high score, or I mean, it is make that clinical accuracy will be high or much closer to the original text. Does that make any sense, Dr. Malaz?
Excellent. And the idea is basically when a patient is diagnosed with dementia here in the US, they will be forwarded or provided with some information, the patient and their family. And these are written in sheets we can access from WHO, from other big providers here in the US. So what we did is we looked at these informations that are provided to the patient and their loved ones, and we found that most of them are written in higher level, and we are aiming to reduce the level of the readability for this information for the caregiver and the patient, so that it makes sense for them as far as instructions and what to expect and what to do in cases. So this project is basically simplifying the readability from level. Here they go by I don't remember
I
the
think, it is 74% improvement readability with, the level is decreased from 15.9 to 4.2.
So basically, from high school level to
Yeah,
grade level or fourth grade
yeah,
level.
primary, yeah.
So language, but at the same time, as you mentioned, it did not remove clinical information or meaningful information as much, and there is no hallucination as much also.
Yeah, yeah. Thank you,
Thank you
Dr. Nadir.
so much. Thank you, Dr. Asma. Thank you, Dr. Nadir.
You are welcome, Dr. Milad. I also practice some question with AI. Some questions like why did we choose these three models? And my answer that this and it is clearly mentioned in the poster that these models are the most accessible for public or widely used one. Am I right, Dr. Nadir?
Yes.
And other question like which is better? And my answer there's we didn't compare between them. Just we evaluated their accuracy and their readability and their compassion or their empathetic tone.
Yes.
I guess we lost our voice.
And I think just to add to that is it's an important question and it's interesting area for future studies if we want to pursue, like we want to compare different AI tools and their responses between either these three or maybe more we can add and then see if there are differences between them and so on. So it's interesting question. I think we lost her, but she will be back. In the meantime, anyone with questions or new ideas for new projects or updates or wants to be involved in research projects? Any comments from you guys? Please feel free. The floor is yours.
Hello, Dr. Nadir.
Hello, Dr. Nabiha. Go ahead.
I just had a question regarding the link to the grand round of University of Michigan that has been posted. So, number one was can we interact during those grand round sessions too, or are we only there hearing the grand rounds and understanding what's being talked about? Or how does it go about? Because I haven't really attended any virtual grand round before.
Dr. Nader, you are muted.
Thank you. Thank you so much, Dr. Nabiha, for this great question. Yeah. So basically, if you go to the app, there is this University of Michigan internal medicine grand rounds, and you can get more information about it. It's 12 o'clock around on Friday, so it's gonna be every Friday, and you have the link for the Zoom meeting, I think. Or they have their own, and you have the password. In the past, we have same internal medicine grand rounds here in Lansing Spare Hospital, with Michigan University. So basically, it will have a 1 hour presentation, including 15 or 10 minutes for questions. So if you are interested in a topic, let's say, and you have some information, there is no problem asking this question at the end of the grand round. And sometimes they will have their contact information for the presenter. If you don't have time during that period, maybe you can obtain the information and then contact them after the presentation to follow up and see. But in the past, most of the fellows in this program, they attended the grand rounds here in Lansing remotely. They used Zoom in the past here, and Spero now is acquired by University of Michigan. So I found this link, and I want you to use this as a tool for you, especially those who are not familiar with the system here. You can have some ideas about how things are done, and it's going to be helpful for you. Also, you can mention that in your application you are attending these internal medicine grand rounds virtually. And yeah.
Right. Thank you
Thanks
so
for
much,
the
Dr.
question.
Nader. Thank
You're
you.
welcome. And you can give us feedback. Let's say you attend this, it's going to be Friday. Next Saturday, if you are here, maybe you can give us a feedback and what you learned, or summarize what they mentioned. So it's going to be beneficial for those who couldn't attend and they are interested in these topics. And sometimes these are recorded, so we can have access to them, but I'm not sure. We need to figure out in the future. In the past, I for major topic, I contacted the presenter, and they were grateful to communicate and share the presentation. So some of the recorded videos in the app are actually some of the presentation in the internal medicine grand rounds here in Lansing. So thank you for the question. Yeah.
No problem. I will definitely attend, and then inshallah I'm also going to give my feedback.
Appreciate it. Thank you so much, Dr.
Thank you
Nabiha.
so much.
Yeah.
Sorry, Dr. Nader and everyone. My laptop was disconnected. Sorry.
Yeah. We understand there are some issues or some no worries.
Yeah.
So yeah, what I answered one of the question about let's say they want you to compare, did you compare the tools against each other? So your answer might be, this is an interesting question. We did not do comparison, as you mentioned, but it might be a good idea for new projects in the future.
Yeah, this perfect answer. Thank you, Dr. Nader.
You're welcome. Do you have other questions that you want to share?
I think no at this time. Yeah, but I will keep practice. Yeah, and yeah, I will ask AI to give me some questions to practice how to answer the other questions.
Yeah. And if you want to practice with some of the fellows, you can invite them, and you can do like last week or the week before, when you on Sunday, you work with Dr. Melaza and the other group, Eugene, I think. So you can also practice get feedback as well.
Yeah, of course, yeah. Okay, yeah. Thank you.
You're welcome. Thank you so much, and I wish you good luck. Anyone else? Any other questions otherwise?
Dr. Nader, actually, interesting to doing an like new project. Okay, so one new project will gonna be for Dr. Nabiha, inshallah, because she interesting to doing project in family medicine. Okay,
Sure, yeah.
Because I found here like this conference also give her opportunity for publication. So it's
Great.
gonna be a great opportunity. Okay. And here also project about the critical care medicine. Okay. And this will gonna be about the advanced technology and treatment for diabetes. And here we have even so two projects for pediatric. Also, the two conferences give us all those conferences give us opportunities for publication. This one and also this one will gonna be in Copenhagen. Also, will gonna be give us opportunity to publish in the critical journal. And this one too. Yeah, both of them is for the diabetes technology. Anyone please interesting, text me, okay, to add you after like finalizing the protocol and so on and receive approval from Dr. Nader. We're gonna proceed, inshallah. Also, Dr. Nader, I wanna. Actually, I need you like 15 minutes. I'm sorry. I don't know if you have time or not. Just after finish, because here, if you know about the research center in the Copenhagen, actually, my uncle worked there in the research center, so I want to do collaboration. So I need your advice regarding that. Okay. This research center actually, Dr. Nader, mainly worked in hematology, for doing studies regarding the leukemias and so on. And actually, my uncle like told me, okay, why not, for example, like doing projects and so on, and we can do even so collaboration with them. Because he is the vice, you can say, manager there, and it takes me a lot of time and told him, okay, let us just doing the project and so on, and then we can do collaboration. So just I need like your advices and discuss all the points if you have time after like the meeting.
Sure, we can do that after the meeting. We can, if you have time, we can discuss. So thank you so much. This is a great opportunity for collaboration.
Yeah, thank you so much, Dr. Nader.
Thank you for sharing. Yeah, this is an important point. So
Please, actually, because I know Dr. Nabiha want to do residency for family medicine and even so pediatrics. So if anyone guys like applying even so like Dr. Nabiha for matching, I know that you need opportunities in publication and so on, and to be like, for example, as first order. I don't have any problem. For example, give you the opportunity for that. If anyone applying and want me give you opportunity, you can text me, and there is no any problem, inshallah.
Inshallah. Excellent.
Thank you all.
Thank you so much, Dr. Malas, for session and providing these opportunities. Excellent.
Thank you so much.
Thanks.
And yeah, even so, Dr. Nader, I'm sorry, if anyone interested in any, for example, topic and need any help, for example, doing like literature review or trying to finalize the title and so on, and yeah, feel free even so to ask me or to reach me, inshallah. I'm trying to help as possible as I can.
Excellent. Thank you so much for that as well. Anyone else wants to share or ask?
I would just like to thank the presenters for today's session. Thank you so much.
Thank you again. I'd like to thank you all for attending this meeting. Thank you for great presentations. All of you did wonderful job. And thank you for the updates. And I wish you all the best. If you have questions, please let us know. I'll be happy to answer any and help you guys. And I'd like to thank those who will come and watch the recording in the future. Thank you in advance, and we'll see you next week, inshallah. Assalamu alaikum. Fi amanillah.
Thank you so much.
Assalamu alaikum.